Ladies and gentlemen, please welcome your panel on the cost of chronic disease and the future of treatment, moderated by Director of Health Economics Research at the Milken Institute, Dr. Hugh Waters.
This is great. It's good to be here. Thank you all very much for attending. My name's Hugh Waters. I work at the Milken Institute. I'm the director of the program in health economics research. And we have some really incredible panelists here to talk about chronic disease in the region. So I'm going to just quickly introduce the panelists. From my left, Dr. Hawaa Almansoori, who's a consultant endocrinologist and deputy medical director at the Imperial College London Diabetes Center here in Abu Dhabi. Thanks for being here, Dr. Almansoori.
You're very welcome. My pleasure.
Dr. Frida Lewis Hall, executive vice president and chief patient officer at Pfizer. So thank you very much for being here also. Captain Nancy Knight, who is also a doctor. For the purposes of this, I'll address her as Captain Nancy Knight, who's the director of the Division of Global Health Protection at the Center for Global Health within the Centers for Disease Control and Promotion in the United States, obviously. So, director of the Division of Global Health Protection in the Center for Global Health at the CDC. Thank you for being here also, Captain Knight. And Mr. Sumit Jamuar is chairman and CEO of the Global Gene Corporation. Thank you very much also for being with us. Okay. So we have a few things to cover today. We're going to look at the general burden of chronic diseases in the region, talk a little bit about how that has grown over time, and also look at some solutions for the burden of chronic diseases. Okay. So when we say chronic diseases, it means literally diseases that take duration over time. We sometimes contrast them with infectious diseases, which you have and they're gone. Chronic diseases are diseases that are with you for, if not for the rest of your life, for a considerable amount of time. The most common chronic diseases, both in the MENA region and internationally, are coronary heart disease, congestive heart failure, so diseases of the heart in general, cancers, stroke, diabetes, kidney disease, arthritis. These are all considered to be chronic diseases, and that's the focus of our session today, both in terms of the prevalence, the costs, and solutions to what's becoming a ever-growing chronic disease epidemic in the region. Okay? So one of the themes that we'll be striking is the lifestyle factors that are related to the chronic disease burden. Okay? So one of the leading ones is diabetes, which is caused in many cases by lifestyle factors, diet, lack of exercise. Okay? Diabetes and obesity are very closely linked. And in many countries in the region, in the MENA region, between 1/3 and 1/4 of the adult population has obesity. So that's measured in terms of body mass index, comparing your weight to your height. So using the body mass index, between 1/3 and 1/4 of the countries in the region have obesity. And if you look at combining obesity with what's classified as overweight, you put those two categories together using the WHO definitions, which are based on body mass index, again, the ratio of weight to height, you can see that almost 2/3 of adults in the MENA region either have obesity or are overweight. So it's a growing crisis, really. And it's not just in the MENA region. It's an international crisis. My country, United States, 72% of the adult population are either overweight or have obesity. So we've got a long way to go in the US as well. One of the reasons we're concerned with obesity, lots of different factors, is the very tight link between obesity and several very important chronic diseases. Obesity is a known causal factor for coronary heart disease, congestive heart failure, strongly linked with diabetes. So people who have obesity, who have a BMI that puts them into the category of having obesity, are 3.4 times more likely to have diabetes than people who have normal weight. So if you have obesity, you're 3.4 times more likely, all other things being equal, to get diabetes. So that's a major issue in the region. We'll talk about obesity and the link with diabetes, because diabetes is itself a very important problem in the region. And managing diabetes is going to be one of the principal themes we'll be talking about here. So enough said in terms of entree. I hope I haven't kind of depressed everybody in terms of laying out the picture, but there's a logic to this. By putting out all the bad news at the front, we're hoping to inspire discussion of where do we go from here? What are the solutions? What are approaches from medical standpoint, from epidemiologic standpoint? How can we address the chronic disease burden before it gets worse than it is, and how can we turn it around and make it and improve it over time? So again, very, very pleased to be here and to be able to introduce our panelists. I'm going to start with Dr. Hawaa Almansoori. So you work here locally with patients in the UAE. And can I ask you, in terms of your practice and the patients you see, and also your public health experience, what are some of the trends in diabetes in the region, and particularly in the UAE, and both in terms of prevalence and also in terms of treatment of diabetes cases?
So thank you. First of all, it's an honor to be invited. You're absolutely right. It is a global crisis. I would like to emphasize is that the MENA region is quite broad. As you said, the prevalence or the rates of diabetes can vary widely, and it makes sense. I have a unique experience in that I trained in the United States for 15 years, so I have my knowledge from there and the practice is there. And I've come here and adjusted my practice to the area, and I've been given the opportunity to manage basically the largest diabetes center in the UAE and perhaps the Middle East. Now, I say perhaps because I have to go do my homework to find that out for sure, but I'm pretty sure. We see about 60% of the diabetics in all of the UAE. So we're a pretty good resource for data and also seeing trends in the community, and also a very important source of treatment. So to answer your question, before I go to the UAE, what I wanted to touch upon, and I believe it's already been presented in one of the other sessions, is just general stats. According to the International Diabetes Federation, where we source these statistics from, keeping in mind that some of the data is not accurate just by the nature of how it's gathered. It depends on people locally diagnosing it, it depends on people reporting it, and it depends on how that gets translated into the publication. So keeping that in mind, about 35 million adults are living with diabetes, according to the IDF, in the MENA region. The prevalence can be, in general, 9.2%. Again, this varies from place to place. And of course, because we're in Milken, and a lot of us are into investment and economy and all of that, it translates into money, bottom line. And the IDF has an interesting number here. It says that it cost $20.5 billion was spent on healthcare for people with diabetes in the MENA region in 2017, and that this figure is estimated to increase by 81% by 2045. Now, I would need a calculator to do that math, but it is a huge number. And this is why it's now a subject in conversation in many economic forums, not just from a clinical perspective. Now, to make it more relevant to the UAE. In the UAE, the estimated number or data for how much diabetes is prevalent is about 1 in 5, depending on what sources you read, and some of them say 1 in 4. And these are the diabetics. There's also a category called pre-diabetes, which is you're not a diabetic yet. That's a hemoglobin A1C of 6.5 for anyone that's wondering, but you're already at risk or have higher sugars. So if I lump that into the statistics, it's probably, I don't know, half of the UAE population falls into the category of pre-diabetes or diabetes. It's a scary number. Yeah. And like you said, it's very much related to lifestyle. And I am focusing on type 2 diabetes. There's different types. And I am focusing on type 2. So in terms of the prevalence, that's the latest data that we have, and I do see that in my patients. In terms of treatment, treatment obviously varies widely in the MENA region depending on the capabilities of the country you're talking about. Some countries obviously have the resources for the latest and greatest. including pumps, including combination medications, pills, injections, and then you go into the issue of refrigeration. So it depends really on which country you're talking about. In the UAE, we're quite blessed. We have the resources. Our leaders have taken very good care of us, and I'm very thankful. And it's our responsibility to deliver it with good conscience to our patients. We have everything from oral medications to injectables to the pumps to whatever machinery there is for monitoring sensors. But the number one treatment, and I want to emphasize this, still is and will always be for type 2 diabetes lifestyle modification. My patients ask me often, what's the latest pill? Well, I'm not going to start with a pill. I'm going to start you with change your lifestyle. Lose the weight, live a healthy lifestyle. So I always tell medical students, number 1, 2, 3, best treatment for diabetes is lose some weight. But if I were to say after that, obviously there is the efforts to broaden awareness amongst the patients of this fact. And subsequent to that, if you fail, there's many different treatments, like I said, all of which, alhamdulillah, are quite available in the UAE.
Great. Thank you very much.
You're very welcome.
Okay. What we're going to do here is we're going to do one round of questioning for each of the panelists. And then, with time permitting, we're going to come back around for another. So we want to make sure that we have time to get through the first round of questions, and then we'll proceed to additional questions as well. Okay, so moving along to Captain Nancy Knight. Okay, working with CDC, it's a great position in terms of being able to observe the trends, the epidemiologic trends, not just in the U.S. but worldwide. And as well as anybody, increasing prevalence of chronic diseases makes us really need to understand the risk factors, the lifestyle risk factors. And we've talked a little bit already about obesity, diabetes, and understanding risk factors within population groups. And so, as we move forward in terms of technology and technological advances, how do new technologies allow us to improve data collection, monitoring, risk factors for these chronic diseases?
Thanks very much for that question, and really it's an honor to be here with the other panel members and with all of you today. So as you heard from Dr. Almansoori, she really talked a lot about the importance of behavioral change for her patients in the clinic. At the CDC, one of the things that we're very focused on is providing information to Dr. Almansoori and to others who are practicing clinical medicine, as well as to the governments themselves, to the ministries of health and national departments of health, so that they can better understand what are those primary risk factors that are contributing to diabetes, to obesity, to cardiovascular disease, to all of these non-communicable diseases in their countries and in their populations. So I'd like to start with talking a little bit about what we're doing in the United States in that regard when it comes to data collection. And so in the United States, we have something that's called the Behavioral Risk Factor Surveillance System, which is a huge telephone-based surveillance system that we've been implementing since the 1980s. We started off with reaching about 15 states, and now it covers all 50 states in the U.S. And it's moved from being a landline-based, do you remember those? Like landlines, they had cords, they plugged into the walls. So it's moved from being a landline-based telephone survey to being a mobile phone-based survey. And it captures data from more than 400,000 adults over the age of 18 every year. It gives us information about behavioral risk factors, it gives us information about access and utilization of the healthcare system, and it gives us information about prevention efforts that patients are using. So now let's take a step away from the United States and look at globally. How are we gathering data globally as it relates to non-communicable diseases? Globally, we in the US, you in the UAE, and countries around the world work with the WHO on our data, our guidelines, our implementation of those guidelines. So with WHO, there is a household-based survey. People go house to house. It's part of it's called the STEPS survey. So part of a routine household-based survey, which is fairly intensive if you think about population-based for a nation, having to go to enough houses to get data that's representative enough to be able to make statements about what those primary risk factors are in your country. It's very important. It's very high quality data. We need to do those kinds of surveys, but we can't afford, in terms of the manpower and the planning and the financial resources, to do that on an annual basis. So typically these are done about every maybe 3 to 5 years in a given country. So what I'd like to talk about then is, what do we do in the meantime? How do we provide data? How does a government provide data to its people, to its clinicians, and to its citizens about the risk factors more frequently than every 3 to 5 years? And that's where something that is called the Data for Health Initiative Mobile Phone Survey comes into play. This is a partnership that CDC is involved in. It's funded through Bloomberg Philanthropies, so it's a good example of a public-private partnership that we have. And it's implemented not just by CDC, but in conjunction with other partners, Johns Hopkins University, University of Melbourne, and WHO, as well as another NGO in the US called Vital Strategies. So our role in this survey has been to take a open source technology that's called Surveda, and we have applied that to implementing this mobile phone survey for non-communicable diseases. We've taken some core questions from that STEPS survey, and we've put it into a mobile phone-based platform using Surveda, and we work with ministries of health, we work with mobile phone companies that are servicing those countries, and we train the members of the Ministry of Health and the community on how to work with us on implementing this survey. So in the MENA region, Morocco is one of the countries where we're implementing this survey. Outside of MENA, we are also implementing this in Ecuador, China, Ghana, India, Indonesia, Malawi, Peru, the Philippines, Sri Lanka, and Zambia. So a number of countries that we're very interested to do this. We're doing it in conjunction with the STEP survey so that we can compare the results, and then we will be implementing it. Ideally, the country could move towards doing it on an annual basis after that. So I'll talk a little bit about Zambia first, because that's where we have completed the survey. And in Zambia, we've been able to see some very interesting results. We were able to reach more than 6,000 adults through this mobile phone survey. We had, the survey was conducted in more than 8 languages, so you could reach individuals who maybe don't have the ability to read the SMSs on the phone. They could get voice prompts and have the questions asked to them by voice. And through the survey, we were able to see things such as about 4 out of every 5 adults in Zambia are not getting the recommended amount of fruits and vegetables in their diet. Conversely, 4 out of 5 are also putting a lot of added salt into the food that they eat. We also got some really interesting information on tobacco use, on alcohol use, and we're working now with the government of Zambia on how they can take that information and apply it to their public health programs that they're implementing to reach the population. We're really looking forward to getting the data from Morocco. Right now, we're actually in the middle of data collection. If you had this meeting in a couple of months, I'd probably be able to provide you with the results. We're about 78% complete with data collection, and we anticipate having those results by the end of April. And when I say we, I don't just mean the CDC. We do this with the ministries of health. So one big part of our goal is that the ministries of health, that the governments that we work with, will make this information publicly available, just like they do with their STEP surveys, so that not only they, but their surrounding countries in the region, for example, can also see what's happening in their neighboring countries. And eventually, that can lead to learning from one another, too, on some of the best practices in terms of strategies that you're then implementing to impact change in that data.
That's great. The CDC is really taking a lead in terms of collecting information, but also using it then in terms of next steps on treating chronic diseases. It's fantastic to hear. Yeah. Mm-hmm. Thank you very much. All right. Well, I'm going to turn to Dr. Frida Lewis-Hall. And first of all, thank you very much for being here. And having somebody with your perspective, an executive vice president for Pfizer, chief patient officer, is is really a great way to get an additional insight into this chronic disease epidemic and where you think it might be going. So what is Pfizer's experience in terms of treatment and wellness options in the region here, and how are those sort of evolving as time goes on?
So again, let me say how honored I am to be here with the esteemed panelists and with the esteemed audience. So one of the exciting things that's happening, I think, are the same things that were represented by the previous two panelists, and that is we realize that it is not a single thing like a treatment option, but instead data collection, surveillance, prevention, through lifestyle modifications, education, and supporting kind of community awareness, having appropriately trained and a full range of deployable healthcare professionals, great centers of excellence, and on and on. But if I press pause, I would say that as a pharmaceutical company, we realize that some of the most important partnerships that we have are really around prevention, patient education and awareness, partnerships with providers, and actually ensuring that patients understand their risk, the nature of the illnesses that they've been diagnosed with, the importance of both their lifestyle interventions and adherence or safe, effective, and appropriate use of the medicines that we provide. And I'll give you a couple of case examples. We haven't talked a lot about cancer as an important non-communicable disease, but it's certainly on the rise. Clearly, obesity, diabetes, and cardiovascular disease is what will bring us to our knees most quickly, but just on its heels will be cancers. And a recent experience that we had in Saudi Arabia suggested that the pressing need was for community education because only 50% of women there understood the importance of regular self-examination or routine examination with a physician by kind of appropriate age and risk factors. So that's half of women who may potentially be at risk. And 55% of breast cancers were diagnosed in advanced stages. So the urgency for education and awareness for routine self-examination and examination in the context of a physician became important. And so we engaged with healthcare providers and mass media outlets to do that education for women to try and increase the number of women who reported themselves as aware, but also reported in for screening, and also to bring down the percentage of women who were diagnosed at advanced stages. A second oncology example is, I'll call it more advanced and required a lot of work with the physician and treatment community, and that had to do with the precision medicine options that are available. For example, in non-small cell lung cancer, there are treatments that are available according to the mutations that exist in your cancer. So I guess 30 years ago, we talked about cancer as one thing, and everything was divided up by organ. What we now know is that cancer is thousands of things. We just weren't smart enough back then to know what they are, but we came quickly up the learning curve. So one example of non-small cell lung cancer is a specific mutation called an ALK mutation. This mutation often occurs in people who are younger, non-smokers, and women. And many people are not aware that they are at risk. They're not aware that their cancer might be different and respond to different kinds of treatments. And physicians, in particular those who are not in centers of excellence or who are specialists in this particular area, are not aware as well. And so developing a diagnostic that is easily deployable and usable in a community setting, ensuring that patients and their families know to ask, and that physicians, referring physicians know to test, and that treating physicians know that there are an array of treatments that would be available by these differing characteristics. So from the simplest of educational paradigms to the most complex, we've discovered that not only is our responsibility to bring the most sophisticated cutting-edge treatments to bear, but to also make sure that people are aware and capable of taking best advantage of them and to have access to them. And there's another area that I think is extremely important, and that is in the area of clinical trials. And it seemed like a secret society, you know, at one point. Nobody knew where they were happening and who was participating. And, but we understand that more and more, that it is important to have the clinical trial participants, patients who have a variety of diseases or those in whom we're trying to present diseases, that we really understand the complexity of the kind of entire human living paradigm. So what part do your genes play? What part does your metabolome play? What part does your microbiome play, like all the bacteria, viruses, and other stuff that lives on you and in you? How do those things play together with your environment to put you at risk or to protect you from disease? And how am I different from you in important ways that we would respond to medications, for example, or other forms of treatment? And so we're really driving to try and educate people about clinical trials, to make sure that we understand as much as we can about differences and how they drive risk and response, and to also make sure that the trials that we conduct reflect the people who ultimately will be treated with the treatments that we develop.
That's great. So moving way beyond the role of a traditional drug company in terms of understanding, obviously, all the complexities of the population and the culture. And
it's a new day.
The behaviors as well. Exactly.
It is a new
great.
day.
It's great to hear. It really is. Okay. All right, so let me turn to Mr. Sumit Jamuar. First of all, again, thank you very much for being here. We'll talk a little bit about genomic data, which sounds potentially like the use of genomic data could be very promising in terms of treatment of chronic diseases. But a lot of the data that we have so far accumulated comes from white Caucasian populations. So does that create, in your mind or from your experience, does that create a systematic bias in terms of being able to apply those findings to populations in other part of the world, and particularly with a focus maybe on the local population here and what their genomic data might look like?
Thanks, Hugh. Hi, can you hear me? First of all, I'm, again, to echo my fellow panelists' sentiment, I'm honored to be here, both in presence of such distinguished panelists as well as in company of this audience. You know, we are, if I look at the emotion, we are moving from a very depressing emotion on looking at the situation as is, and increasingly we are moving towards a solution. Because as we look at the disease burden, what I'm excited by is the technological intervention about the possibility of genomics allowing us to know who we are, understand and make personalized recommendation. And it's not about an event happens and something needs to be done, but it's about how do we stay healthy. Thank you. How do we stay healthy? You know, how do we make sure that we are, you know, we don't have to go through that disease paradigm event. How do we mitigate the risk before it actually takes place? And I think for us, and that's what is incredible about the promise of genomics. Now, I'm the only non-doctor on this panel, right? So I look at things slightly differently because you look at, coming from a different industry, you look at things and say, clearly there's something wrong. This system can't be that broken. At the end of the day, the system is about each one of us, and the patient and the individual has to be at the center of it. But if you look at the incentives and everything else in the system being created, it actually incentivizes being unwell and going for treatment rather than encouraging us to maximize our life's potential. So going back to the point that Hugh made, you know, what the CDC is doing and what Nancy talked about is incredible. And we got inspired because it started with a very simple conversation with my co-founders at Harvard. I was a banker at that point of time, and I walked in and I said, these guys started talking about this thing called the DNA. And it was remarkable because you suddenly said, oh my goodness, if I have the instruction operating manual for each one of us, the instructions for each one of us, imagine what we could do with it. And being a data geek, you started saying, this is remarkable, can you do that for me? And my colleague, who's still a faculty at Harvard, he's turned around and he said, Sumit, I can sequence you, which is I can write your book of life. Think of your DNA as your book of life. I can transcribe it into machine-readable information, but I cannot tell you anything interesting from that or relevant from that. And my first reaction was, why not, right? And he said, because I do not know what a good Sumit who comes from India looks like. Because he said, at that point of time, 96% of all data and insights came from people of European descent, right? Even now, 81% of that data comes from people of European descent. Of the remaining 19%, 16% is from China, and it is, due to the way the laws are structured, it is within China. So we have a situation where when you look at Middle East, you look at Asia, you look at Africa, over 60% of the population comprises less than 5% of genomic data and insight. Now, why is that valuable? Because on one hand, I'm talking about a promise of precision medicine, where and simply it means to the right person, the right drug, in the right dosage at the right time, and solving for diseases. On the other hand, I'm saying, but I don't have a reference of what it looks like. And to many of my financiers' friends, I explain it's like comparing a bond index to your equity fund and saying, I did a great performance, didn't I? Right? So, and that's what we're solving for. So what we are doing is we're creating highly curated data insights in populations which have not been covered before. We started in India, and in the right ethical framework, collecting all the phenotypes which you could look at so that we can draw correlation studies, and then building the genomic data assets and insights around that. And I think without solving for that bias, what is going to happen is that promise, that amazing promise that we have in terms of precision medicine, is never going to come to realization. And a couple of things drew me out in terms of the insights that we have discovered. There was a situation where in published literature when we started, there was something which is supposed to be what is a driver mutation. And in simple terms, it's a spelling error in a book, in the DNA or the book of life, which was supposed to cause epilepsy, right? So we took it in a healthy cohort of people of Indian descent, and we tried to test it. And we found that 96% of those people who were healthy had that particular mutation, but none of these adults had ever displayed any symptom of epilepsy, right? So we just went back and we said we must have done the experiment wrong. And we realized that the experiment was correct. It was the interpretation of the data was wrong, because while it was driver for the Caucasian population, it was just a genetic variation in the Indian population, right? I take another example because Frida talked about the non-small cell lung cancer. Remarkable, if you look at response rate, 5% versus 75%. It is the difference between life and death if you have certain mutations. I'll take another example of another population like the Icelandic population. There were certain people who never had high cholesterol. And then they looked at that cohort and say, why do they never have high cholesterol? And they found there was a particular gene called PCSK9 which was inhibited. They said, let me take that experiment and see if on a global population of people with high cholesterol, if I were to do that, inhibit the PCSK9, does that lower cholesterol? The answer was yes, and you have a blockbuster which is PCSK9 blockbuster. So the way to think about genomics is it offers the promise, and as we build these insights in different populations, we find that there are unique characteristics which have global application, which will give us the next generation of drugs, which will make drugs development faster, better, cheaper, and those statistics are incredible. So everything from clinical to this gives me a cause for optimism, but we have to solve the fundamental problem, which is what Sean Parker and Brian Johnson were saying yesterday, was, look, you can have all the machine learning algorithm, but if your training set is biased, you're never going to get to the right solution. And that's what we're solving for, and that's why I'm so excited to be here on the panel here.
That's great. Thank you very much, Sumit. Well, a lot of interesting insights from the first round of questions. And I'm thinking what we might do is, in terms of moving this forward, is maybe we could, all of us, sort of think about the trends that we're looking at in terms of chronic disease levels in the region, in terms of the risk factors for chronic disease, obesity and others, and also in terms of treatments. Where do people see the treatments going as we move forward here? So what we could do here is just kind of open it up, and we can, all of you can please feel free to chip in and answer that. And we have to be a little bit mindful of the time, but we can have some more of a conversation about where are we going in terms of risk factors, in terms of treatment, and what's the future look like in terms of treating chronic diseases here in the region and elsewhere.
So if I may, if
Please,
that's okay,
please do. Yeah.
I would like to kind of address some of that
That'd
and
be
also
great. No, I think
encourage discussion.
All of us can, yes.
And build upon what you already said. I made myself a few notes here so I don't forget what I wanted to say. I think we've all hit the nail on the head, but from different perspectives. The one thing I would really like to speak towards today, and which was brought up, which is genomics, genetic sequencing, and benefiting from the information from the book of life, as you put it. I'm very excited, but I'm also the type of person to not be naively so. Especially if you look at the media, especially if on my ground level, patients come to me and they tell me, oh, there's this new gene out there, do I have it? Should I get sequenced? Aside from the many institutions that are considering doing more genetics, aside from people consulting me in regards to insurance coverage and et cetera, and get the cascades down. In the end, it's the patient we deal with. I would just be careful, like you said, because I'm a prime example. I worked in a population genetics lab. My genes got sequenced for lactose intolerance. It was for fun. Someone comes up to me and says, hey, are you lactose intolerant? I'm like, no, you have the gene. I'm like, great, good to know. Just because you have the mutation or the gene can mean absolutely nothing, or it can mean everything. So taking it with a grain of salt, and unfortunately sometimes I have to be the one with the reins going like, whoa, it's great. Like you said, great potential, but I want everyone in this room and everyone that listens to this conversation to realize that it's also, it has a lot of pitfalls right now. It can actually cause inappropriate treatment. It can cause you to worry inappropriately. It may cause, imaging studies that you don't really need because, it's also important to understand what you're looking at. So I'm very optimistic in terms of genetics being a diagnostic tool, being a treatment tool, creating medications specific to individuals, not just populations. But again, take it with a grain of salt and be aware that the people, if governments decide to apply this, I have no objections whatsoever. Just make sure it's experienced people that actually know what they're talking about, because this can be taken in many different ways and it can be misapplied horribly. So that's just my little tidbit about the genetics part. And then the second thing I just wanted to touch upon is, I hope everyone in the room knows that even the normal ranges of your labs are based on Caucasians. Let me touch upon a big one in the UAE, vitamin D. If I hear one more patient that has a hemoglobin A1C of 12 and I'm worried about a stroke, come to me and say, yeah, but doctor, what's my vitamin D? You had 2 stents, you're about to have a heart attack, your hemoglobin A1C is through the roof, I'm worried about a stroke. Yeah, forget all that. What's my vitamin D? I totally understand it's a joke, but I understand the concern, but this also comes from the fact that I argue that the normal ranges, again, are not necessarily applicable to, for example, the UAE population or, I don't know, the Indian population or such. So again, even the basic normal ranges that when a doctor looks at the computer and tells you it's normal, take it with a grain of salt, because we know for a fact that, for example, people in the U.S. from African American descent have higher muscle mass. So their creatinine ranges, as for your kidneys, can be normal, but they'll come up as high on the computer. So it's not necessarily correct. And you need to have trained professionals, trained clinicians to be aware of this and to apply it in their practices. And again, if you take it at a larger level, this will save you money, because if you have the right people in the right places, you apply the right treatments. And on the government level, need to be aware. And for example, we're gathering data to find out what osteoporosis is to us. What's the FRAX score? We use something called the FRAX score. Again, we don't have one for the UAE population. So again, just being aware of these issues and knowing where to plug in this information to best benefit. In the end, it's us that we're benefiting, the patients. We're going to be a patient one day, whether we like it or not. And also I agree that it's really, actually someone at the World Government Summit just a few days ago said, it's not healthcare, it's sick care. So it is important, like you had touched upon, to focus on prevention. It's time to kind of take a 180-degree turn and say, okay, let's not wait until you get sick. Let's actually prevent you getting there. And that's a whole mindset that needs to change from government to hospitals, to physicians, to medical, everyone involved. And I think the UAE is actually doing a very great job, and there's new policies and there's new informative programs and public health stuff that is really focusing and trying to change people's thought processes to prevent rather than just treat the disease.
Thank you.
So,
Please.
I just want to make I do want to put an exclamation point behind the points that were just made about the need for data, and not just by country, by region, or by race. I spent a number of years looking at sex differences or gender-based differences, and everything from receptor site density in the brain that are different from women versus men, and women of certain ages versus women of other ages. And so at the end of the day, I think ultimately we'll have the capacity to get down to a diagnostic us, if you would, a diagnostic avatar. And many people are moving in that direction, where we have your genome, we have your phenome, we understand your environment more fully, we understand the various components that affect you, and that we'll have enough data and powerful algorithms to really begin to have a diagnostic platform that is you. That'll give us, and when I say diagnostic, I don't mean to figure out in what way you're sick, but even in what way you could stay well. If you think about diet and exercise, that's like one of my favorite. I'm sorry, what diet and what exercise? Because I'm a little confused right now. And, right, because if what's healthy? Is it really the vegetables? Is it real? I mean, because we sway. If you read 20 years ago, it was one set of things. If you read 20 weeks ago, it was another. And I suspect that we're going to continue to evolve that. And I think in the same way that I use the oncology example, the prevention example still needs some refinement, and that is, I need an avatar about me that would be more specific, that would characterize me better, and would be better able to predict what would prevent disease for me. So I guess this is my, wave to say, for those of you that are in data collection and data analysis, or could be, this is such an important area for us in medicine, because we are on the road, but we haven't arrived yet.
Thank you so much. Maybe,
Sure.
Captain Knight, maybe if you have any thoughts on where we're going with the chronic disease epidemic.
Thank you. And just to kind of follow on what you've just said, Frida, you're absolutely right. There's a need for that translation of population-based data, whether that population-based data is at a country level, at a regional level, at a ethnicity level, or at a community level. It still has to be translated at the interface. When a patient, a client goes in and sees their clinician, there has to be a discussion around that data and the applicability of that data to each and every patient as they walk in the door. And I really thought the example that you gave about the genetic mutation that in one population contributes to epilepsy, but in the Indian population just happens to be there at this point, is a really good example. If you were to take the data and apply it incorrectly, you could be giving really wrong clinical guidance to a patient that's not actually at risk. I think I want to take a step down to kind of the community level as well, and talk about that interface of data for a community and data for the clinician. And a lot of that revolves around the workforce. In many countries, we have really strong clinicians, like Dr. Almansoori, who's here with us this afternoon. And yet many communities do not have that level of clinical services available to them. They don't have that level of physicians, of nurses, of pharmacists to really be able to take the data and interpret that data and help to apply it to them. And that's true for high-income countries, that's true for middle-income countries, that's true for low-income countries. We have huge health disparities in the United States as well in some of our rural and very urban populations. One thing that I think it also boils down to is the workforce. So what are we, that's what I would like to talk a little bit about, is what are we doing about the workforce? And how are we helping the workforce to really be able to understand and take all of this information that comes in from social media, from published articles, and often when that information is in conflict with one another. One of the things that we are doing with many countries is working with them on helping to build their expertise in epidemiology. And that's something that we're doing not only at a national level, but all the way down to more of a community level. And this is through something that's called the Field Epidemiology Training Program. That's sort of a mouthful. We like to call them disease detectives. So these disease detectives are people that we train. It's actually based on a training program that we've had at our CDC headquarters for years and years and years, called the Epidemic Intelligence Service. If you saw the movie Contagion, there was an EIS officer that unfortunately passed away in the movie. We try not to do that on a regular basis with our EIS officers. But it's a really important training program for people to understand how to interpret data, how to collect data, how to do that in a quality manner, and then how do you translate that to the people that you're serving. So in the MENA region, we're working with a number of countries on their field epidemiology training programs. We have field epidemiology training programs in Egypt, Iraq, Jordan, Morocco, Saudi Arabia, Yemen, Tunisia, and Pakistan. And we focus on training a cohort of individuals for 2 years. Those are the folks who are really the cream of the crop, working usually at the national level on national level data interpretation and application to policies and programs. We also, in many countries, are training people at an intermediate level, so maybe more at a provincial or regional or state level, so that they can translate their data and application of that around communicable as well as non-communicable diseases, around injuries, around violence, around road traffic accidents, and we're training people at a lower level, like at a district or a community level, through something that's called a frontline program, which is a 3-month program. So that's, I think, another important aspect that we don't want to forget. All of these factors have to come together, and you have to have high quality amongst all of them in order for, in the end, for whether it's the genetic information, whether it's the information about drugs and therapeutics, or the information about behaviors and risk factors, we have to be able to pull it all together to really be able to serve the patient and the community.
That makes a lot of sense. And the point about collecting data that's locally relevant or relevant to specific countries, specific settings, certainly makes a great deal of sense. And it's great to hear about CDC's efforts in that regard. But thank you so much. So if I could turn to Sumit Jamuar in terms of your thoughts about where this is all going. How are we going to adapt and address the chronic disease burden in the future?
So the way we think about it, and I think the panelists, we have had some conversations on the sides, and I think we all view this. I mean, the way to put it in context is it's an immense technological disruption. Because now we have if you look at two secular trends which have taken place. The first is the cost of sequencing, which is writing that book of life, for example, has become 2.7 million times cheaper in the last 15 years. It costed $2.7 billion. It took 13 years. Now we can do it in a few hours for less than $1,000, right? And it's going to get to $100 at some point. At that point, I expect that every child who's born is going to be sequenced because that's the best way to gain information insight about them. The second thing is, remember, this book of life is 3 billion words. And if I, as a normal human being, read at an average speed, it will take me 9 years to read through that entire book of life. So the second secular trend is
Does
this
that include
incredible.
time to sleep and eat and things like that?
Absolutely. So it's AI and machine learning, which allows us to look for needle in the haystack. So over the last 30 years, it's become 1,000,000 times better. It's going to be 1,000,000 times better over the next 30 years. And it's become real cheap because I can go on cloud compute and everything, and I have the same access as what supercomputers and big countries and others have, right? So when you combine those two things with the fact that there's so many smart people who are crowdsourcing, looking at ideas, finding solutions, and the industry is working with small companies, with researchers, and when you look at the ecosystem, that ecosystem is really promising. So I go back to the point of saying this is the same stage at which internet was in 1995. Right? Amazon was just invented. I just want to visualize that context. Amazon was just founded. Google was not invented. We did not even think what an iPhone or a smartphone would look like. It would take another 10 years to get there. Now, if you look at the big revolution from the information technology revolution or internet revolution to the revolution we are having in system biology, it is going to disrupt everything. And so if I am sitting here, I'm really excited, and I think all of us are excited about the possibility. What we have to be mindful of is exactly what Hawaa said or what Nancy said. How do we keep it simple, right? It's the KISS principle. How do we keep it really simple? Because doctors are really busy. You can't tell them, hey, you need to look at another genetic parameter. So what we do is, but we do know the mobile phone. For example, we use this app to provide pharmacogenomics views, right? All you need to do is you need to type in the drug name. It goes in the cloud, checks against my gene, and tells me whether that drug is suitable or not. That happens in real time. So the doctors don't necessarily need to know in this evolving field of genomics what they need to do. You make it simple. The patient gets control of it because the patient can then say, no, it's not lying in some black box. It's something I have with me. And I think that's the way it's going to happen, and that's the way it's going to go. So, my thought is, look, I'm an optimist. If I was an optimist, I wouldn't be sitting here. I think the industry, what I'm absolutely delighted by is when I engage with partners in pharma, when I engage with partners in clinic, when I engage with clinicians, when I engage with partners in public policy, is the overwhelming desire and excitement about adopting things. And I'd just like to leave you with one thought. I look at the next generation, and I'm really excited. So my son is 4.5 years old. At this point of time, when he looks at technology, it's a part of him. It's not an alien thing. He comprehends data, he takes different sources, he draws insight, and he comes up with certain insights, which I'm like, wow, how did you come to that conclusion? When I look at that skill capability which is generated, that's where all the training resources and others are coming in. So when you look at the next generation, they're going to think about things in a completely different manner, but they will be able to assess all these things and put them in place to have a more mature system, which will have impact on each one of us.
Great. Well, we've actually been able to go then from a very pessimistic beginning with me talking about chronic disease burden and costs to concluding with some hope for the future in terms of new treatments and ways of monitoring and addressing the chronic disease epidemic. And thank you so much. And let me just take a second to thank all of the panelists. This has been a fantastic discussion. I've certainly learned a lot and look forward to when I feel like I have some new inspiration to go out and address this issue on a number of different fronts. So thank you all, and thank you to the audience for your attention. And I think we're all would be available to respond individually to questions or by email and such. So again, thank you very much.
Thank you.